All right. There's other areas too.
So
let's talk about those.
We can take Thomas's.
Poor Thomas, he just took his
know,
eye off. If people can see this, he
Bone
just took
off,
took his eye off. And so what he did is now he's looking at the left eye, the bones around the eye, and then the temporal area. So if you go from your eye and you go to the outside where your sideburn is, that's kind of the temporal area.
Right. And so, the nerves above the eyelid, above the orbit or above the eye, the supraorbital and supratrochlear nerves, they go through variably either holes or notches in the bone, in the superior orbit or the eye socket. And so a lot of times there's compression there. And so we'll go and we'll actually unroof what's called a foramen, or the hole that the nerve goes through. If it's a notch, which is also common, a lot of times there's this fascia or connective tissue that's forming a bridge over the notch. We'll release that. We'll release, as here we're looking at the corrugator muscle, and we'll trace the nerves and all of their branches through the muscle to try and release these areas as well. A lot of times there's blood vessels associated with these bundles will ligate or disrupt, cut those blood vessels, so they're not a problem. And again, tracing the nerve from the deeper portion through all of these areas of potential compression out towards and to the subcutaneous tissue.
And you're coming at that superiorly. You're coming.
No, so there's
coming?
two ways to do this.
Okay.
So there's the this endoscopic way, which is the way Dr. Guyron originally described it, and then there's it's called the transpalpebral or upper eyelid approach.
So it's just real quick, it's the same incision or the same scar you would have if you went in and did your eyelids for cosmetic reasons. So
Correct.
It's in the crease of the upper eyelid.
And a lot of some patients they'll say, okay, well let's
Let's go ahead.
get my eyelids
in there.
done.
Let's get my
too,
migraines
right? So,
and my upper eyelids taken care of.
Yeah.
right. So this is an aesthetic scar, right? You're gonna end up with basically a very, very, very fine transition or a white line in the upper lid, in the fold of the lid, where people just don't see things, right? So that's a very, very well tolerated incision. And then, lateral to your eye, you have crow's feet.
Right, which means to the outside of your eye.
Right,
Everybody
thank
knows
you.
the crow's feet.
And so in here you can see this is the zygomaticotemporal nerve, which if you feel this bone on the side of your eye and then you push towards your ear, you'll see there's a little divot, there's a little depression there. And that's where the zygomaticotemporal nerve is.
Right, and if you've always seen the classic thing when people have headaches, they're kind of rubbing their temples.
Right.
They're literally rubbing right in there.
Right in the nerve,
nerve.
trying to release
Right.
that, and they don't even know that they're doing this,
Right.
right? But so we can use those crow's feet incision, this upper lid incision, and have it go into the crow's feet to access that nerve.
Cat eye eyeliner.
There you go.
Stretch that out.
Right, so we already used that incision from a cosmetic standpoint, so it's well known to heal well and not be a problem.
Very rare. I mean, I use the same incision when I'm doing mid-face lifts.
Yeah.
And so, which was interesting to me because when I learned how to do all of this surgery, like, oh yeah, I know that nerve, you'll know, is right next to the
Right.
sentinel vein, right?
Right,
I mean,
right.
you know exactly. You've seen. I've been looking at this nerve for years, right? But now we're doing a similar operation for a different reason. So so that nerve will either decompress through the temporal muscles, or sometimes that nerve will just get cut.
Because
again,
the distribution for sensation for that nerve, the
Very
zygomatic
small.
temporal, is small, and you can cut that.
Exactly.
Whereas the ones, the supratrochlear or the supraorbital, which again is above in your eyebrow area, you don't usually cut those because those are a little bit more.
Right, you try not to cut that. But
Okay.
as you know, whenever we do a brow lift or talk about doing these kinds of things, one of the risks we talk about patients is that we have that nerve cut,
Yeah,
right?
nerve injury.
And fortunately, knock wood here, never happened to me. But one of the risk factors is that you would have a numb forehead, and we certainly want to avoid that. So those nerves, when we're identifying the nerves and actually tracing them out through the muscles, the only really way they get cut is if we're doing it intentionally,
Okay.
right? Because we're going in to look at the nerves, right? So
I mean,
we
there's
trace
part of
them
this
out.
is a little bit funny because in plastic surgery we spend so much time not cutting nerves.
Right,
and-
trying
Yeah,
to
we're
avoid
trying to
them.
avoid.
Yeah.
I mean, that's like
Avoid them.
the
Yeah.
main complication
Yeah.
with most cosmetic procedures.
Yeah.
We actually cut the nerve.
Right,
These-
but we also, we spend a lot of time avoiding the area of the nerve. Here,
Exactly.
we're actually looking at the nerve.
And going in
And
it.
so when you're looking at the nerve, it's hard to cut it unless you're trying.